Welcome to the EP Tech Podcast, where we learn and burn. This is where we turn up the heat on electrophysiology. I'm your host, Luna, a new EP Tech who knows how hard it is to find practical information tailored to the EP world. Each week, we will dive into tools and topics that will help you grow your skills and knowledge. Whether you're scrubbing your first ablation or troubleshooting like a pro, this is the burn you'll actually thank us for. So let's plug in and power up today's episode. Welcome back to the EP Tech Podcast. I'm your host, Luna, and today we are going deep. And I don't mean into the septum. I mean into the cardiac conduction system. Today we're going to be covering where the electrical impulse starts, how it travels through the heart, why this matters, and trust me, it does. How to identify normal sinus rhythm, and what happens when that spark goes rogue, aka arrhythmias. So grab your badge, your notepad, or your lead vest, and let's get into it. We are going to start with the spark that starts it all, the cardiac conduction system. Think of this like the heart's version of a well-coordinated marching band. Every player has their cue, their timing, and their position. One mess up and suddenly the tuba is soloing during the flute section. Not good. So again, every heartbeat starts with an electrical signal that tells the muscles when to contract. This signal follows a very specific path, and understanding that path is the key to interpreting EKGs and diagnosing arrhythmias. So we are going to start with the SA node. This is the heart's natural pacemaker. It is located in the upper part of the right atrium near the opening of the superior vena cava. We call it the pacemaker of the heart because it initiates the electrical impulse. The SA node will automatically generate impulses about 60 to 100 beats per minute under normal conditions. These impulses are autonomic, meaning they happen without any external trigger. The SA node has automaticity. After the SA node initiates this signal, the impulse is going to spread across the right atrium and through the Bachmann's bundle to the left atrium. This ensures that both atria contract simultaneously, pushing blood into the ventricles. Next, we have the gatekeeper. This is what we call the AV node. The AV node is located at the junction between the atria and ventricles near the tricuspid valve. The AV node plays a vital role by delaying the impulse. This delay is about 0.1 seconds and allows the ventricle time to fill up with blood from the atria before contracting. It is important to note that without this delay, the atria and ventricles would contract at the same time and the ventricles wouldn't fill properly. After passing through the AV node, the impulse is going to hit the bridge, which is what we call the bundle of His. This is located in the upper portion of the interventricular septum. This is the bridge that sends the signal from the atria down to the ventricles. And if you listened to my last episode, you know that I have a provider who's very, very animated and absolutely loves when we see the His signal on the intracardiac. But let's keep moving on. As the impulse is going down the bundle of His, the bundle of His actually splits into two, which is the right bundle branch that travels to the right ventricle and the left bundle branch that travels to the left ventricle. The left bundle branch further splits into the anterior and posterior fascicles. These branches are what's going to allow for fast conduction towards the apex of the heart. Then we have the final step, the Purkinje fibers. These are fine fibers that spread throughout the ventricular myocardium. Once the impulse reaches the Purkinje system, it causes the ventricles to contract in a coordinated fashion. The contraction starts at the apex and moves upward, pushing the blood into the pulmonary artery and aorta. So let's do a quick recap. So our impulse is going to travel from the SA node to the Bachmann's bundle, to the AV node, to the bundle of His, down your bundle branches, remember you have your left and your right, and then into your Purkinje fibers. Okay. Now you might be thinking, Luna, that's cool, anatomy, physiology, yada yada, but why is it important? Well, let me tell you why. First, this pathway is what produces the ECG waveform that we read on a daily basis in the lab. And I just want to point out that sometimes you'll hear somebody say EKG, and sometimes you'll hear somebody say ECG. Whatever your preference is, they mean the same thing. It confused me when I was in school, but now I know. Another reason why it's so important is because once we start getting into understanding arrhythmias, if you don't know where the impulse travels, you won't understand what you're seeing on your screen. Every peak and interval on an ECG represents a part of this conduction sequence. For example, the P wave, that's atrial depolarization. That's your SA node to your atria via your Bachmann's bundle. The PR interval, that's the time from the SA node through the AV node. The QRS complex, ventricular depolarization, that's your bundle branches and your Purkinje system. Then you have your T wave, which is ventricular repolarization. So again, if you understand this pathway and understand and gain a real solid foundation of your basics, you're going to be able to identify blocks and arrhythmias. You're going to know why your patient is bradycardic. Shoot, you can predict the problem and how to potentially fix it. Are we going to be pacing? Are we going to be giving meds? Or did we even have a successful ablation? Knowing the conduction pathway is like having Google Maps for the heart. If there's traffic at the AV node, well, hey, you're going to see a PR delay. If there's a roadblock in the bundle branches, you'll get a wide QRS. And if the SA node ghosts the group chat, well, somebody's getting paced. In what we do, your foundation is everything. And that's something that stuck with me with my preceptor when I was going through clinicals in school, was he wanted to make sure that my foundation was solid. And this is the foundation. All right, guys. Well, we're going to take a quick break to give a shout out to the people who really keep our circuits firing. You're listening to the EP Tech Podcast, brought to you by Don't Miss the Hiss and Don't Miss a Beat, because in this field, missing either one could shock your whole rhythm. These are hands down the best visual textbooks because they are bold, visual, and built for learners who like their conduction clear and their catheters clean. I wish I had these when I started out in the lab. So if you're a visual learner like me, follow them at Don't Miss a Beat and Don't Miss the Hiss on socials. And grab your copy today at don'tmissabeat.store before you're standing in the EP lab yelling, "Somebody page cardio," because your brain just coded. Now, let's depolarize this conversation and keep it flowing, because we're about to identify what a healthy rhythm really looks like. All right, now that we've got a solid grip on how electrical impulses travel through the heart, let's talk about what it actually looks like when everything is working the way it's supposed to. We're diving into normal sinus rhythm. So what exactly is normal sinus rhythm? In simple terms, it is the rhythm we hope to see on an ECG in a healthy, properly conducting heart. To be considered normal sinus rhythm, there are a few key features that must be present. So let's break them down one by one. First, it originates from the SA node. This is non-negotiable. If the rhythm doesn't start in the SA node, then it is not sinus. That is a key point to remember. Sometimes you'll see rhythms labeled sinus bradycardia or sinus tachycardia, but the key word here is sinus. That tells you the SA node is in charge. Even if it's firing slower or faster than normal, it's still in charge. Second, it has a regular rate of 60 to 100 beats per minute. We want a nice, steady beat. If you're between 60 to 100 beats per minute at rest and your SA node is running the show, you're likely in sinus rhythm, normal sinus rhythm. Again, under 60, that's sinus bradycardia. Over 100, that's sinus tachycardia. But keep in mind, context matters. An athlete might have a resting rate in the 50s and be perfectly healthy. A dehydrated patient or someone who's anxious might run at 105 and still be normalish. So we're always reading the rate in context. Third, your P waves are upright in lead 2. The P wave is the footprint of the SA node. On a standard 12-lead ECG, lead 2 gives us the clearest view of atrial depolarization. In normal sinus rhythm, the impulse travels from the SA node down towards the AV node, which matches the direction of lead 2. So the P wave should be always upright in that lead. If the P wave is upside down, flattened, or missing entirely in lead 2, chances are the rhythm is not originating from the SA node. And here's a pro tip as well. The P waves should all look the same. If they're morphing shape beat to beat, think wandering pacemaker or multifocal atrial rhythm. Those are a little bit more in depth though, and we'll get into those in another episode. Fourth, one P wave for every QRS complex. This tells us that every atrial contraction is triggering a ventricular contraction as well. The AV node is doing its job, letting the signal through without dropping any beats. If you see extra P waves or dropped QRS complexes, you might be looking at a heart block. If the P waves and QRSs are totally unrelated, that's third degree AV block. And that's not normal sinus rhythm. That's a medical emergency. Next, we want a normal PR interval. This is 0.12 to 0.20 seconds. The PR interval measures the time it takes for the impulse to travel from the SA node through the AV node and into the ventricles. A normal PR interval tells us there's no delay or block at the AV node. So when we look at this, if the PR interval is too long, think first degree AV block. If it gets longer and then drops a beat, think winky block. If it's all over the place or there's no clear pattern, you're probably outside of sinus territory. Lastly, we want a regular rhythm. This means the PR intervals, the distance between QRS complexes, are consistent. You can check this by using calipers or marking beats on a paper. If the rhythm is all over the place, it's not normal sinus rhythm. A good example of this is sinus arrhythmia. It's still from the SA node, but the rate varies slightly with respiration, speeding up as you inhale, slowing down as you exhale. It's common, especially in younger people, and usually nothing to worry about. So, a key tip when you're just starting out and you're just familiarizing yourself with arrhythmias or even normal sinus rhythm, when in doubt, ask yourself these questions. Are there P waves? Are they upright in lead 2? Is every P followed by a QRS? Is the rhythm regular? And is the rate between 60 and 100? If the answer is yes to all of those, well, congratulations. You're probably looking at normal sinus rhythm. And if not, well, hey, it may be time to dig a little deeper. Now, what happens when this elegant system goes completely off the rails? That's where arrhythmias come in, and here's where EP becomes not just fascinating, but life-saving. I don't want to overwhelm you guys too much when it comes to arrhythmias. There's so much, as you've seen, just for sinus rhythm, there was a lot. So we're going to keep it basic and just kind of go through what happens when the primary pacemaker fails or the secondary pacemaker fails. So when the SA node fails to fire, the baton usually gets passed down to the AV node. It's like when your boss doesn't show up and the assistant manager steps in to keep things running. Not ideal, but still functional. The AV node has automaticity, meaning it can spontaneously generate impulses if needed. Its intrinsic rate is slower than the SA node, usually around 40 to 60 beats per minute. So if the SA node stops working from things like sick sinus syndrome, ischemia, medications, the AV node can step in and keep the ventricles beating, just at a slower, more relaxed type of pace. But then what happens when the AV node fails to step up? Luckily, the heart still has a third string quarterback. It's the Purkinje fibers and ventricular pacemaker cells. These can generate impulses too, usually around 20 to 40 beats per minute. So if both the SA node and the AV node are down, the ventricles say, fine, we'll do it ourselves. It's slow, inefficient, and usually symptomatic. Patients may feel dizzy, lightheaded, or even syncope, but the heart keeps beating. This is called a ventricular escape rhythm, and it's kind of like driving a stick shift in first gear. It gets you moving, but you're not going anywhere fast. So again, back to your basics, you're going to want to make sure you understand the hierarchy of the pacemakers, from fastest to slowest. Your SA node, the boss, 60 to 100 beats per minute. Your AV node, the assistant, 40 to 60 beats per minute. And then your ventricular pacemakers, which is your Purkinje fibers, they're the intern that's just trying their best. They're about 20 to 40 beats per minute. Each level only takes over if the level above fails. So you'll never get a ventricular rhythm if the AV node is working. So let's just do a fun clinical example. Let's say the patient presents with a junctional rhythm at 50 beats per minute. That tells you the SA node isn't working and the AV node has taken over. This is common in sick sinus syndrome or in cases where beta blockers or calcium channel blockers suppress the SA node function. Now, let's say you see a ventricular escape rhythm, wide QRS complexes, no visible P waves, and a rate of 30 beats per minute. That's your heart yelling Mayday, all systems down, usually from complete heart block, but it could be after cardiac surgery. Again, understanding this foundation and having a good base is going to help you get far in the EP lab. So how do we recognize these on an ECG? Just quick, brief, and easy to go over. We'll kind of go more in depth again in another episode, but if your SA node is in charge, then you are in a sinus rhythm. P waves before every QRS and a normal PR interval. If your AV node is in charge, you're going to see absent or inverted P waves, narrow QRSs, and a slower rate. Now, if the Purkinje fibers are in charge, you may need some help, but you're not going to see any P waves. You'll see wide QRSs and a very, very slow rate. It's like checking who's driving on the bus. You'll notice the ride gets bumpier the farther you get from the SA node. Before we wrap up, let's bring it all together. We've walked through the entire electrical highway of the heart. From the SA node initiating the spark, through the heart's internal relay system, each part passing the signal with precision to keep the beat alive. We've talked about what happens when that system runs smoothly and what happens when it misfires. Whether it's sinus rhythm cruising along like clockwork or the AV node stepping in when the SA node checks out, understanding this system is the first step in becoming an expert in the EP lab. Because once you truly know how it's supposed to work, you can quickly spot when it's not. And in this field, that kind of awareness saves time, saves energy, and sometimes saves lives. Thank you for listening to the EP Tech Podcast, where we learn and burn. If you like this episode, share it, subscribe, and stay tuned. And hey, if you're ready to upgrade your learning game, use the code LUNAEP at checkout to get a discount on your visual EP and cath textbooks at don'tmissabeat.store. Because clear conduction and clean caths start with the right tools. Until next time, stay grounded but electrically curious. I'm your host, Luna, and I'll see you guys next time.